and welcome to today's webinar, Why Primary Care Providers Need Social Determinant Data. My name is Laurel Rodriguez, and I am the Director of Marketing at Ecovia Solutions. Today we will be discussing how the social determinants of health play a role in primary care, the importance of working with community partners, and strategies for getting started. Our presenters today are Dr. Wyatt West and Ecovia Solutions' Sam Taylor. Wyatt West is a family medicine and weight management physician at Tanner Clinic in Roy, Utah. He runs the Mountain Valley Weight Loss Program, where he works closely with his patients to develop individualized care plans that foster a healthier lifestyle. Tanner Clinic is independently owned with 6 locations in Utah. As a patient-centered medical home, Tanner Clinic offers more than 30 diverse specialties and performs many ancillary services in order to coordinate holistic care for their patients. The state of Utah has multiple statewide systems of care for high-risk populations, such as the homeless, individuals with substance use disorder, and emotionally troubled youth. Tanner Clinic is among the many healthcare organizations in Utah who provide primary care services for these high-risk populations. Sam Taylor serves as the Director of Solutions for Ecovia Solutions. His focus is on the development of programs and services that enable health and social service organizations to work together to address the social determinants of health. Sam is an accomplished project management professional and is the leading force at Ecovia Solutions for implementing technology and processes for healthcare, public health, and social service organizations. Dr. West, I will go ahead and turn the time over to you.
Well, thanks, Laurel. It's fun to be here and fun to talk to everybody about this important part of primary care and about healthcare in general. Now, whenever we do some sort of a talk about healthcare and the problems we face and the challenges of healthcare, it's impossible to get away without talking about the money aspect of it. Healthcare is an incredible field of work and really exciting, but it's also incredibly expensive. Just last year in 2017, the best estimates are that we spent about $3.2 trillion in the United States on healthcare. I mean, sometimes when we see these huge numbers, it's hard to really wrap our mind around it because we don't have a point of reference. Just to put that in perspective, the gross domestic product, so basically all of the money that changed hands last year in the United States was $18.5 trillion, just a little north of 18.5, which means that 1 out of every $6 that was spent last year in the United States went towards some aspect of healthcare. The amazing thing about that is that these numbers continue to rise. In the next 6 years, it's estimated that about $1 in $5 spent in the United States will go toward healthcare. Now, the dirty little secret in all of this is that most of the people listening to this webinar, myself included, we didn't spend 1 out of every 5 or 1 out of every 6 of our dollars last year on healthcare. Really, there is a disproportionate amount of healthcare spent on a relatively small group of people, and these high utilizers have become big focus for those of us trying to figure out how to better manage healthcare, because if we can make even small to moderate interventions in these people's lives, we could potentially not only save them a lot of problem, but also save the overall system a lot of money. So this tends to be a lot of our focus in a lot of the new accountable care type interventions that we've been working on for the last few years in healthcare to try to address the real high utilizers. Now, all of us know someone who contracted some awful disease and has become, not by their choice, one of these high utilizers. But these people are actually fairly rare. A much bigger proportion of the high utilizers are people who get into a high risk their access to healthcare. I think people who have poor access to healthcare tend to, rather than being proactive about their medical problems, tend to be more reactive. And when that happens, we take healthcare out of some of the less expensive platforms like a primary care context and shift it over to more of an emergency room context, or they're getting their health care in a hospital where it's much more expensive and intensive and invasive for the patient. I like the little the part about education. You know, education is a huge aspect of a person's health. People have quantified this before, and education seems to be the single greatest determinant of a person's overall health in their life. The higher the education a person has, the more likely they are to have good health in their life. And addressing this part of healthcare is absolutely essential if we're going to talk about caring for the whole person, their economic stability as well. If they can't afford the maintenance parts of healthcare, then unfortunately they get shifted into more of a reactive area of healthcare, or they're getting their healthcare in emergency rooms. And so all of these social determinants really fit in to how well a person is going to be during their life. And so if we're going to really care for people, we have to do so in more of a holistic manner. Now, it seems to be that the primary care environment is really the best environment to take care of a person's whole needs. It's a fairly inexpensive place to take care of people's needs, and really comprehensive. We can do a really good job if we have all the tools. This is especially true when it comes to taking care of people's chronic health conditions, these conditions that people develop over time and tend to stick with them for most or all of their life. One of my primary focuses is on obesity in this arena, but diabetes, autoimmune conditions, hypertension, hyperlipidemia, coronary artery disease, and the list goes on of these chronic health problems. You know, interestingly, in more modern healthcare, cancer has become one of these. Most people with cancer don't die quickly. Cancer has become a chronic disease because of advancements in treatment, but it brings up a whole new element of challenges in care as well. So for me in my particular practice, I'm a family doctor, and early in my practice, I started noticing that as I was seeing people and I was diagnosing them with conditions like diabetes, like hypertension, like obesity, that if the patient took a lot of initiative and made a series of lifestyle changes, oftentimes their disease condition improved or even resolved. And as I started seeing this happen time after time, I became very interested in more of a preventative care, which got me interested in the treatment of obesity. And now I do this as a major part of my practice. When I have a person come in to see me for obesity treatment, I'm not just treating them for weight loss. The weight loss is nice, but really what I'm doing is I'm treating all the chronic conditions that come along with their obesity. And as the diet improves and as the exercise habits start to get cemented in, and as the person starts to lose weight, lo and behold, all of a sudden they're taking less medications for diabetes, and their blood pressure medicines become obsolete, and all these other problems start to disappear. Now, one of the big hurdles that I've had in getting my weight loss program going is I have had to realize that I don't have time to do all of the counseling necessary to help these people change these major lifestyles. And I have had to start to incorporate the help of dietitians and other medical professionals and staff to help my patients maximize their weight loss and achieve their goals and maximize their outcomes. And I think that's a good analogy for the subject today, because in my primary care clinic, when I see somebody in an area where that's relatively underserved, poorer economically, and a lot of my patients have major hurdles to getting the care they need. When I see them in clinic, I have an average of about 15 minutes with a patient. And in that amount of time, if that person has 3 or 4 chronic conditions plus one new medical condition that they want diagnosed and we need to start on a treatment plan for that, I just don't have time to address all those issues, plus make sure they have adequate housing and that they know what types of foods are healthy and that they have enough money to buy those foods. And oftentimes with my older population, they can't drive anymore. They have transportation issues, and if I think that they need physical therapy because they're dizzy and they're falling, they can't get themselves to a physical therapy office. And the list kind of goes on, and I just don't have the ability to address all of those issues in just a 15-minute time slot. So as a primary care physician, as a weight loss physician, I need help from other people. So this is kind of a good segue into considering these social determinants of health, because we can do our very best to treat the person's health conditions, but if these conditions go unaddressed, it makes it very difficult. Sometimes these conditions are the actual root cause of their health problem. Sometimes it's just complicating their health problem, and in order to care for this whole person, they're going to need a lot of resources. And for most of us, the resources exist out in our communities. We just need help plugging them in to these different community resources. And I think that's where kind of this platform comes in. So some sort of community health worker, whether it's a social worker, a nurse, that's kind of the idea behind a medical home model, is the physician is taking care of the medical issues, or the provider is, and then they have people who are plugged into all these different community programs, accessing them and expanding the network or broadening the network of actors that are helping this person deal with their chronic medical problems. And by so doing, we can get a lot better control of these issues. We need people to, these patients, high-risk patients, high-utilizing patients, they need people to walk them through these different steps. Accessing all these different resources is difficult enough for somebody who knows how to do it, let alone somebody who doesn't. And so tracking them, following up, screening them for all of their needs, assessing what all their needs are is absolutely essential in caring for the whole person. That's why this is a great quote. It says, "The solutions to today's complex problems can only be solved by multiple organizations." And I think multiple organizations is the key, working together across traditional boundaries. And so overcoming all these hurdles to plug a patient in who's a high utilizer, who's high risk, into all the different community resources is going to be the best way to totally take care of them. And coordinating this on a primary care level is really the best place to do it. It's the most cost-effective place to do it, and it's probably the most effective, health-wise, the most effective way to do it.
All right, well, thank you so much, Dr. West. I'm going to turn the time over to Sam Taylor.
Right, so in this last segment, we wanted to share some information and some of our experiences working with collaborative organizations in a collaboration to address the social determinants of health. And we've worked with a wide range of organizations who are doing so, between payer type of collaboratives, accountable care organizations, communities that have had collaborative organizations driven through a county or a partnership at the city level. So we've seen a lot of different strategies and practices that have emerged, and so we'll just spend the next couple of slides here discussing what we've seen and some primary questions we think that a community should ask or providers should ask as they're trying to participate in the kind of partnerships to address the social determinants of health. One of your primary things that you'll want to do, first off, is to identify the goals and to try and focus in the goals of the partnership. These goals will help you identify what kind of decisions you want to make about the types of data sharing you might do, the type of referral networks you build, types of providers that you engage in the community, and your goals will also help measure your progress. We'll talk a little bit about that later on, but it's important to understand if the collaboration is working. And without goals or something to compare against, it would be pretty difficult to tell whether or not you're moving forward. One of the main things we see, too, is folks that will identify the target populations. This could be a single target population or it could be multiple that they're trying to address. This helps focus the partnership's activities so that you can identify the right way to identify people who might benefit from such collaboration. And let me give you a few examples that we've seen. So we work a lot with folks that are homeless or at risk of homelessness, so the housing social determinant of health. That's a very common target population. Also a target population where you've seen these types of care coordination really benefit that population. And we see this in a variety of instances, from housing for health programs to programs that are HUD funded in various communities around the United States. Another good example of a target populations are individuals who are transitioning out of certain types of institutions. So foster care is a good example. Also institutions like criminal justice system, hospitalizations, even behavioral health clinics and so forth. As individuals transition from different care settings, oftentimes what's understood by one provider who's serving them is no longer known. Oftentimes during that transition to a different care setting, there's a lot of risk to the individual because we're not continuing on a care plan. We're not continuing on our understanding of what they need, and sometimes those needs can be unmet as they transition to a different care setting. Another thing you want to do as you're trying to begin this type of collaboration is identify the scope of services. So if we went back to our target population and the homeless population, shelter would definitely be part of the services and the scope of services. And identifying the scope will help you identify the type of providers you want to reach out to. So in the shelter example, we'd want to identify the variety of shelters in the community. We'd want to reach out to those. And whatever other target population you're working with, that will help you determine what the scope of services are. And also the needs of those populations. So issues with nutrition, whether that's not the ability to not find food or the ability to not get the healthiest kind of food, there are community providers that can definitely address those needs, but being able to identify that's one of the services you're looking at will help you look for providers in the community for those and select those when you're working in a partnership. One last thing as you're starting down this path is try and take advantage of existing infrastructure and partnerships that are already successful in the community. A couple of good examples. Nearly every community in the United States has some element of 211 in their community. 211 has a referral network. The services are defined according to a rational way of organizing those services, and oftentimes your 211 partnership will help you determine who in the community can be providers of these services that address the social determinants of health. And we've seen 211 partnerships in multiple communities around the United States. In fact, I've talked with a couple of organizations that are just starting their process of addressing the social determinants of health, and that's one of the first places they turned, is to the 211 organization in their community. Another example of existing infrastructure that we work with quite a bit are coordinated entry projects. So HUD provides funding to address homelessness through a special needs office, and one of their grants that they provide requires the establishment of a coordinated entry system in each community across the nation. And these are in a variety of different stages of development, but nearly every community will have some coverage by this coordinated entry system. The coordinated entry system is used to have a community-wide inventory of housing where you can manage capacity at a community-wide level. Community here, they actually have a defined term. It's a COC, a continuum of care, and covers a geographic region of some kind. So like here in Salt Lake City, there's a COC for Salt Lake City. So coordinated entry would establish the inventory of housing, but it also establishes entry points so that when people are referred for housing assistance or come seeking housing services, they are assessed in the same way, and then they are referred out to individual shelters based on their needs. One of the intents here is to address the most vulnerable first, and also try and address folks that have special needs with special shelters that can meet their needs. It's a really good way of consolidating housing services for a community, and it's definitely a great place to start if you're looking to start a collaboration in your community related to housing. A few other things to note, and this definitely has a data perspective, as you would expect with an organization like us, where we primarily do work on the electronic health record side or the side of data exchange. So one of the first things that needs to be discussed and thought through is consent and compliance to regulations. Freely flowing data is certainly a good thing, but I think we all understand there's certain trade-offs in terms of privacy for individuals. And you want to be able to protect their privacy, and you also want to prevent things like identity theft. And for organizations, you want to prevent HIPAA breaches, and you want to prevent other problems where you might be non-compliant with federal regulations or local regulations. So one thing you'll definitely want to think through as you're looking at these collaborative interactions is, what is the consent that's going to help us cover it, right? And what kind of administrative processes and administrative decision-making are we going to put in place to make sure that there's a consent that will apply? There are certainly examples of this all over the nation where, clients seek services, they sign a release of information that covers the referral and the share of some information, and then another organization might have a further consent and consent to receive services and so forth. But you'll definitely want to think this through. This will be important on a lot of levels, and especially making sure we're protecting the privacy of the individual. Another thing that really is beneficial as far as data governance is to work towards a comprehensive health record. We've been talking today about the social determinants, and as many of you know, if you've examined your own EHR, you've seen your health record as you're interacting with your doctor, sometimes those are missing the social determinant data. Sometimes those are missing the income data, the education data, as was mentioned earlier, data about housing and stability, data about social history, family history. All of that data is sometimes missing from the health record. And if a doctor, for example, only gets 15 minutes to see their patient, the more we can get into that comprehensive health record, the better off, better informed we can make them in a short amount of time. So there want to be some thoughts into what constitutes that comprehensive health record in your community. And you also want to think through, what does it take to collect that data? Sure, it would be great to have a very, very full record that covers every aspect of a patient's life, but you also have to consider the administrative burden and who's going to produce that data and make sure it stays accurate and is updated over time. So thinking through some of those problems and establishing some rules, so to speak, in a collaboration would be very helpful in establishing that standard of a comprehensive health record. Finally, as you're thinking about data in a situation, in a collaborative situation, is you want to think about exchanging it. Now, exchanging data can be very expensive. This is one of the big challenges because many systems are not alike, and many systems look at patient identifying information or income data or education or housing status in a little different way. And in order to exchange data and make it really meaningful, you've got to send data from system one and have it have the same meaning in the system two that it sends that data over. This is where the importance of data standards come into play. And in the healthcare world, the primary data exchange standard is HL7, Health Level 7 standards. And these Health Level 7 or HL7 standards help define a common way of looking at things and common way of formatting data, if we want to be a little more precise, for encounters, for care plans, and for other common types of data you want to share. Labs is another good example. The reason you want to think about standards is a lot of the EHRs in the community, especially the hospital ones, will support some of these standards. There's not as much standardization in the human services whereas usually we talk about social determinants of health. But being able to align any of your efforts with those data standards will reduce cost, because most of those systems, at least the health record ones, already have those standards embedded in them rather than have to build them out. Another thing to note when we're looking at the data governance is if your community has a health information exchange. Health information exchange is a type of system that allows for the exchange of data between a lot of others. And the benefit in the community is a single entity, let's say it's somebody who's connecting an entity that's connecting their EHR, would only need to make one connection to this health information exchange. And the health information exchange oftentimes has defined legal agreements, consents, and other important administrative policies that your organization wouldn't have to do. So if you're in a community with a health information exchange, there's a lot of benefit of looking into that as the way to start exchanging and sharing information. And to wrap up on the data end, the last things you want to think, one of the things you want to think about is measurement and evaluation. We want to make sure that whatever type of partnerships we establish is actually meeting the goals that we're looking for. And measurement can actually come in two different levels, and I think many of us understand this distinction where we look at output versus outcomes, or I think utilization is also a good way to look at the output description. And what we mean by that is some data measures just activities. So how many referrals are made in a community? Which that would actually be pretty good information if one of your goals is to establish a referral network and a collaboration. So just the simple ability to count and see, well, did we have any referrals? Did we have 50? Did we have a few hundred? Did we have 0? That simple measure will let us know, is the system even being utilized? And those are generally utilization measures. Outcome measures are a little more beneficial. They're definitely a lot trickier to report, but they will help you understand if you're meeting goals like we are going to reduce obesity in the community, or we're going to reduce the risk of diabetes in the community. Those are a little bit trickier in terms of their definition of what the outcome measure will be, but also how the data is collected. Now, this should be part of your measurement and evaluation planning from the very beginning, but it would be part of the total strategy of what kind of data you're going to collect and measure. One last note here on outcome data. I'd highly recommend looking at organizations like AHRQ and other organizations that actually establish quality standards. Care coordination standards is a really common one for us to look at. They give really good examples of the type of outcome measures that will really tell you if the system is providing quality care for individuals. Now, that mostly covered what we're talking about when we started trying to find what we're going to measure. But there's other things to work out in terms of what kind of data are we going to distribute and who we're going to distribute it to. So what are the stakeholders in your community, and is there value in pushing that information out to them? And then also, as you're considering what kind of data you might push out to different stakeholders, consider the data sharing agreements in the community. Aggregate reports that talk about, that display how many referrals in a community, those are generally fine to start sharing. But if you start sharing individualized information, there needs to be data sharing agreements. I'm thinking back to a couple of slides ago. So determining what data reports we're going to have, what kind of data is in there, but then how are those going to be distributed and to who, just to make sure that we have the right data sharing in place, and also it's the right audience for each of those. Now, of course, you also want to think about who's going to write the reports, so in terms of skill set and what kind of systems they're going to use. There's a lot of analytics tools out there like Power BI, business intelligence tools that allow you to build charts and graphs and present data in a way that makes it a little bit easier to understand and interpret. And then there's also way more advanced stuff if you talk to the data science realm and so forth, where it might be a lot more in depth. Trying to understand your goals around reporting will help you know what kind of tools you may select and how much is invested in measurement and evaluation. So, for example, we worked with organizations who have a measurement and evaluation team, a team of 3 to 4 individuals, and that's their whole goal, is defining what data will be measured, putting it together in beautiful reports, and distributing it. In other collaborations, you have very few resources as far as reporting, and those tend to prioritize stakeholder reports and then reports maybe that need to go back to funders to justify grants or other funding sources for the collaborative effort. Laurel, I think we could turn the time over for question and answers.
Yeah, well, thank you so much, Sam, and thank you, Dr. West, for your presentation. So we are going to open up the webinar for any questions. Feel free to submit them in the chat panel. We have a couple of questions to get started. So the first one is for Dr. West. And so can you talk a little more about addressing the social determinants of health to determine the root cause of patient conditions? How do you do that in such a short visit?
Well, most of it can't be done in such a short visit, and that's the real problem and why we need other people to be helping out in that arena. So when we see a person, there's some work that goes into it before we get into the room that's already kind of populated, some of their historical things, and just as you're talking to the person, you can gather some information. Sometimes it's forthcoming, and sometimes you have to dig a little bit. But as we start to identify, okay, this person, they are elderly, they live at home, they have a hard time, they have to depend on neighbors or family members to drive them places. We start to kind of get a picture just talking to them, and then the task then becomes, okay, how do we refer them to agencies that can address those needs? And so and then we have a network of maybe home health companies and things like that we can start to refer them to. But most of what we do, or most of how we gather that information, is just speaking with the person and following them over time. You get a better idea of kind of what's happening in their life.
Okay, perfect. Thank you. So the next question we have is for Sam, and they say that so we don't have a data and measurement team in our organization. But what are some basic ways to get started measuring the social determinants of health?
One of the biggest places I really like to start is to build on what other organizations have already done. So AHRQ, that is, it's a federal agency that has defined some measurements, especially around care coordination and social determinants, and they have really good information as far as what kind of measures are understood as standards out there in the community. So that's one good place to start, is look for quality measures. There's CQMs as well, clinical quality measures, and there's a few other bodies that produce these. Just by reviewing them, they will tell you what kind of measures are being used in other communities. And a nice element of them is they usually build off of commonly tracked data. So it's nothing that's so exotic that you wouldn't imagine it in your community, and you have to start from scratch as far as collecting the data. Oftentimes they can get that data from basic encounter information and standardized tracking around diagnoses like ICD-10s. So that's definitely one place to start. I would also look at measurement and evaluation organizations. So M&E is a very, very common way of saying it. The American Association of, I think, Quality Measures, there's one of these that has quite a bit of information online. I think it's actually AEA, American Evaluation Association. But these organizations have entire teams dedicated to producing material about measurements. How do you measure? What's easy to measure? What's more difficult? How valuable is a survey versus other types of data? And then they have great examples of presenting that information.
Perfect. Thank you. Okay, the next question is also for Sam, and it is about the comprehensive health record. So what information would you be able to share in a comprehensive health record?
So a comprehensive health record, the information you'd be able to share is what the client consents to share, is a good way to think of this. And there's a type of standard for representing a client's clinical documents called a CDA in the HL7 world, a clinical document architecture. And what's nice is a lot of material online talks about that document, which includes things like your vital signs, includes health conditions, but it also includes behavioral health conditions and social conditions. And they can all be represented in this document. But it talks about segmenting off that data so that you can share it when the patient consents to, and sometimes limiting views of that comprehensive health record. So what I'd recommend is you're thinking about the comprehensive health record and its pieces and whether or not you can share it, is to look for a standard what includes all of the social determinants and health data you're looking for. The CDA by HL7 is a good place to start. In fact, there's a specification of it called the Continuity of Care Document, a CCD, which is a subset of that, but it includes a lot of different sections that will be important related to social determinants of health. Look at that. You can download good presentations on those. It also includes a care plan, which includes good sections for these, and then think about which segments of those clients may have to exercise consent over. Right, and that speaks back to the data sharing agreement. I definitely, when I have these conversations with communities, is what can be shared is what does the client consent to share, and that's a great place to start. One other note here as you're thinking about that, some states have more restrictive controls over certain types of data, HIV data, gender and some identifying information. There's some variations at the state level. So definitely pay attention beyond the regulations at the federal level to your state's regulations governing data sharing.
All right, perfect, Sam. Well, so that is going to go ahead and wrap up our Q&A for the webinar. We'd like to thank Dr. West and Sam for their excellent presentations, and thank you for joining us for today's webinar. And we thank you again. We hope you will join us for future webinars, and have a wonderful day.